Great. Warm welcome, everyone. We're now live. My name is Dr. Fahim Shakur. I'm a general practitioner in the northwest of England. It gives me great pleasure to have convened, with the help of Hannah Sharples and Dr. Michael Finnegan, this special evening webinar, which is aimed at general practitioners in the northwest of England, particularly those around the Preston Chorley, Lancashire Teaching Hospitals area. Over the course of the next 40 or so minutes this evening, we hope to explain a fairly new concept to this area, and it's a special actual clinic that's been designed to help people with symptoms, which is of a rapid diagnostic center, for things that are not quite cancer or fitting the cancer 2-week referral pathway. And where do you send them? I think this has probably been a question and a quandary for many of us working in general practice. What to do with these patients, the patient mix that actually present, how is it handled, and also a contact detail if you've got any queries. What I'd like from all of you tonight is to actually understand how this pathway works in the actual Preston Chorley region. If you've got any questions, we'd like to hear them and we'd like to answer them as well. And hopefully we'll be going through a case study as well during the evening to just actually pen out and actually delineate it in more clarity. I'm not going to say much further except introduce both our speakers now, and then I'll shy away from the limelight. Dr. Michael Finnegan is a consultant gastroenterologist, and he's also an acute medicine consultant there, and has been a leading light for this, along with Hannah Sharples, who's a clinical nurse specialist in the actual centre as well. I think that's enough from me, and if I can hand over to you, Dr. Finnegan, first to start the proceedings, and then with Hannah Sharples as well after that. Thank you so much.
First of all, I'd like to thank you for inviting us to explain a little bit about our pathway and about the service we've set up at LTHTR. So a little bit of background on the intent and purpose of these pathways, first of all. The concept of rapid diagnostic centres is currently replacing what used to be termed 2-week wait urgent referrals, mainly because of a recognition across the UK that those pathways weren't necessarily fit for purpose. And what I'm going to do is talk you through a little bit about the history, about why we set this service up, about where this service is positioned within the region, and how to get patients into it, and also something about our referral criteria and why that's slightly different from other pathways and the reasons behind that. The slide deck is fairly information heavy. I'm not intending to talk through everything that's in the slide deck, but because of the nature of live streaming YouTube, you will be able to pick that apart and pause it and get information out of it if you want. We're not intending to talk for too long today, to just give you basically the reasons, as I said, why we're here, how to get hold of us, and who we feel or why we feel that this is a valuable service for you guys in general practice. And I think we've given this presentation a few times. Most of you will probably, well, hopefully come out of this thinking about 1 or 2 patients it might either apply to or it might have benefited in the past. So I will just share our presentation, and then I'll start talking along with that. So Fahim, because I had to log out because of the connection issue, I'll need to be enabled for screen sharing again.
Absolutely fine. So should be okay too.
That's it, we're good to go. So this is our formal name. We tend to abbreviate to NSS RDC for obvious reasons. I think our name changed quite a few times in our development, and this came out of what used to be called Pathways for Vague Symptoms, but actually that doesn't really cover what we've got, because the vast majority of our patients who come to us have defined symptoms. And the feeling was non-symptom or non-site specific RDC was the correct terminology, despite it being a little bit of a mouthful. So historically, as I said, it's been clear for a number of years that the 2-week wait pathways are very much cancer focused. and we're getting multimorbid patients, and we're getting a rapidly aging population. A large increase in both serious physical illness and cancer coexisting with comorbidity is expected. And the way two-way pathways worked, this was expected to overwhelm the current systems and just provide more patients than diagnostics could deal with. The vision from NHS England, NHS and NHS Improvement was to look at all cancer and non-cancer serious diagnosis pathways and try to catch people early. And this led to a problem because site-specific, or for example, pancreas cancer specific or lung cancer specific symptoms are often preceded by a prodrome of illness where you know the patient is sick but not why. And they were not served well by current two-week pathways. And this is sort of the history about why we're here. The aim of any RDC, but the non-site specific pathways are sort of the archetype and the prototype for these, is to provide a single point of access so that patients who meet the criteria for entering into these pathways shouldn't bounce around between general practice and secondary care. And if they do, they do so for good reason, to make sure that patients come to the pathway able to be investigated. And that's a slight change in flavour from current two-way pathways, where a lot of the delays in diagnosis and meeting the hospital targets are because we can't investigate patients before we've seen them. And this sort of model looks to change that paradigm, so we can streamline and hopefully increase the accuracy of initial investigations, to personalise that, and also to limit patient attendance to hospital and reduce the number of visits needed and the number of trips between hospital and primary care. The aim is to get people early. And the idea is that this will eventually lead to efficiency savings because we're catching people early when they're treatable, and we're not putting as much pressure on sort of the high intensity treatments further down the pathways. From the patient focus, its access, its efficiency, and also its named people and small groups of named clinicians. So you'll speak to specific people. Again, our advantage is our caseload for this. I think it's more challenging for people like colorectal to do that. Getting good quality data so we can plan, and also working as an integrated region. So we network with RDCs in Cumbria, out towards Blackpool, and also in East Lancashire, to try to get a quality of care for patients and a quality of diagnosis across that pathways, and also hopefully to provide mutual aid. So if you can get a CT scan quicker in Blackpool, we can send you to Blackpool. That's not quite there yet, but hopefully that's coming. And in the Rapid Diagnostic Centre sort of prototype specification, this slide really shows, and this is one of the few I'll talk through in detail, it really shows us what we're here for, to get people early, to reduce health inequality, to make it easier to make an appropriate referral, so that it's very clear how you get into our clinics, it's very clear who we'll see, there's a communication between the referrer and the team referred to quite early on. If we think people will probably meet other criteria or are actually a really good candidate for us, but we can't quite get them through the pathway yet, and Emily, our patient navigator, is really the person people referring into this will speak to. The aim is not to be specific on a single tumour group, cancer group, or physical illness. And we've seen quite a large variety of patients within this pathway now, and really we look at all of the systems in detail, and we look at previous investigations, and we try to use that information at our as part of a multidisciplinary process to get the right test at the right time, and that we hope to increase the speed it takes to get a patient to get a diagnosis. And the other thing, which is probably quite interesting for general practice, is that our 2-week wait pathways and hospital referral pathways have been restricted from horizontal referral by cost pressures within the NHS. This pathway and prototype allows us to refer directly to another hospital group for definitive care without us having to bounce this patient back to you and asking you to refer onwards. I think that historically that's been difficult for secondary care to do, must be very frustrating. And I hope that this approach will be taken by RDCs in other site-specific tumour groups as the concept evolves. And underpinning all of that is coordination and support, which is something that Hannah, I think, will talk to you a little bit more about when she goes through some of our patient experience. So again, this will be available on YouTube. You can pause this and look at it if you like. You will also probably have seen this, or you may have seen this come up on your EMIS systems if you're local, and other rapid diagnostic symptom centres outside the Greater Lancashire area will have a similar referral form. It looks at filter function tests, and they're investigations you need to have before we can see you in the rapid diagnostics clinic. And the aim of all of this is to increase throughput and mean that we can stream patients to investigations before we've seen them. And often with these patients, with these filter function tests complete, we know that the U&Es are okay, so we can refer them for a colonoscopy and therefore for bowel prep. We know what their U&Es are doing if we need to CT them. We've got a general idea about general physiology. We've identified other conditions that can present with non-site specific symptoms, and we can stream them to other places if they're more appropriate. And really, if you're referring patients into this pathway, that's why we mandate such a rigorous set of investigations, and why we're really strict about it, because this is what gives us really good outcomes, and this is what allows us to give the speed required of the pathway. Please do consider the optional parts of this investigation, particularly if you have a young patient or a patient who has risk factors. Please do consider checking for HIV. It doesn't require quite as onerous it's sort of counselling process as it used to, and really it's something that is actually relatively common. Presents with sort of protein symptoms, and it's really, really treatable. It's got an excellent prognosis if you get it early. We tried to make this mandatory amongst our region, but there were some issues with that. So particularly if you've got a patient who might be at risk, and that is very broad at the moment, please do check that before you refer, because you've got a good chance of, if that's a diagnosis, getting a patient on really excellent treatment really early, giving them and you a lot of reassurance. These are really our referral criteria. We will see people with unintentional weight loss. We prefer it to be documented, but we know that that's really tricky. We will take strong clinical suspicion. The constitutional symptoms are there. Now, it can be difficult to differentiate this pathway from the rapid access pancreas pathway, mainly because of the combination of weight loss, difficulties with appetite, fatigue, nausea, and bloating. If you're unsure, we'll sort it out between us and the pancreatic pathway and LT-HTR. If they meet the referral criteria, we'll refer them in, and we'll liaise between us if we need to. Our patient navigators will do the majority of that. Again, vague abdominal discomfort, very similar to pancreas pathways. If you're unsure, we can provide advice, either via advice and guidance, which in an LT-HTR catchment is to gastroenterology, but we're trying to set up a separate advice and guidance pathway for us. Now, the bottom one of these is, I think, the patient group that's been clearly missed by 2-week wait. And I think it recognises that general practice is generally a service that knows its patient well. And actually, in the early days of rapid diagnostics and the pilot studies, this was actually the presentation to non-site specific rapid diagnostic clinics that had the highest cancer pickup, between 8 and 9% in the pilots, which is double that at least of most of the 2-week wait, pre-existing 2-week wait pathways. We don't know this patient well. We know that this has a high pickup. We're really keen to know the clinical history and the reasons that you've referred them, because that gives us the best clue when we start taking the patient through the patient pathway as to what's worrying you. Because you'll generally have a relationship with the patient in general practice, and we'll need some help with that subtlety when the patient's presenting. And we might contact you if we know there's something going on but we can't quite work it out. We might be in touch. With that, there comes exclusion criteria, and the main reason for that is resource. The team at LTHTR is myself, Hannah, and our patient navigator, Emily. The service is commissioned at each site within the region independently. And there's my colleagues in gastroenterology cover when I'm away, but they're not particularly familiar with the pathway. I tend to cover for Hannah if she's away, and we both muck in to cover for Emily if she's away. But obviously we're quite resource limited. And again, I don't think the exclusion criteria are particularly unfair, but that's really the reason they're there. If the patient needs referral for another site-specific 2-week wait pathway, we'll ask you to stream into that. If the patient can't get to us or is too ill to go through a clinic process that may take 2 weeks, we will return that referral to you. Mainly because the aim of this is to pick up treatable cancer. If it's clearly obvious what they've got, but again, we're not getting many of these. Usually the referrals that we've had through our pathway have been both appropriate and interesting. We've usually been able to get an answer. The fourth one here is relatively tricky. I think referral patterns at the moment are, as patients come to us with problems they've developed through the COVID period and lockdown, are meeting multiple referral criteria for multiple pathways due to physical illness. And this one is a little bit more tricky for us to interpret, and I guess for you guys referring in as well. And I'd be very interested when we come to the questions point if anyone has any strong feelings about that. For the last one, inappropriate, it's not really the right word, but really we're saying if we know there's something going on but we can't put them through this quickly, we will be in touch about the referral or how to make the referral acceptable. What happens to the referral when we get it? So the referral initially comes into Emily, who's our patient navigator. She will do administrative validation on the referral, check that the referral is complete and that the filter function tests are in date, and then she will flag it to us. She may be in touch with the practice to look for other blood test results or information we haven't got. Or because it's a really central part of our process, if the patient hasn't opted into record sharing within sort of local systems like LPRES or local clinical exchange or single patient care record, we will ask for that to be discussed again with the patient. Because actually we rely on that for quite a lot of their information. We rely on it for drugs and medication history, for past medical history before we've seen a patient, and sometimes we can book discriminating investigations directly from that initially at the point of clinical triage if we've got access to that pool of information. Obviously we know there are data protection concerns about that. Patients may not be willing to do so. We will still see them. It doesn't rule out. It just might slow the pathway down a little bit for them. And then after that process, either myself or Hannah looks at it, and usually Hannah will give them a ring, go through a complete medical history in detail, and use the luxury we have in the non-site specific RDC of time. We're given quite a lot of resource to see these patients, and often they need it. We make an investigation plan personal to the patient after that, and then we decide whether we'll be able to get a diagnosis for this patient purely on investigation, whether we will need to see this patient within the week, usually in a rapid access sort of clinical pathway where we can examine them. And then Hannah and Emily, our patient navigator, will follow these investigations through. So as soon as they're performed or reported, we get the information back into the system. The other side of this is how we document. We've moved away from the classical dictation letter to real-time living document recording of clinical information within Somerset Cancer Registry, and we tend to generate our own paperwork rather than, for the majority of it, relying on a standard discharge letter or clinic letter that's dictated and sits around for some time in admin. As our caseload increases, we may have to look at automating some of that. We're hoping some of the IT changes that we've started will move through and allow us to do that. We'll hopefully be seeing more contemporaneous documentation and information coming out to you guys about our decision process than has been traditional. If the patient is very complicated, bounce between a couple of site-specific 2-weight pathways and things, sometimes we won't do very much before we see them. We will give diagnoses over the telephone. We won't rate bad news if it's at all possible, given the speed of it over the telephone. But we've learnt a lot from COVID, and we've got mechanisms that we can do that. And we've had, in my practice outside the rapid diagnostic centres, we have been able to do that, I think, acceptably over the COVID period. And I think step 9 probably for you guys is another take home. We will generally make on referrals from this process. We will try not to ask you to do anything from this, though we may give treatment advice and indications for the referral. Before we go into the patient case studies, I'll just give a couple of minutes for both for Hannah to prepare for her side of it, and also for any initial questions or comments from Fahim.
That's great, Michael. We've just got a few questions, if you could take them whilst Hannah's ready. So one is that, are there any templates in GP systems to assist with the referral to this RDC? Do you have any templates that either a GP could use or access to actually do the referral?
So our referral form has our GP representative, Alicia, was heavily involved when we set this pathway up. And the referral form and pathway are uploaded to local EMIS systems. And also the filter function tests are on, I think, the GP ICE system as a single request. So it should be relatively easy to get these tests booked. So were there any other questions? So the referral template or referral form should be available within your EMIS. It should have a patient information leaflet attached to it as well. And if you're having difficulties accessing it, obviously we don't see the referrals or how they get to us sometimes. And if you are having problems, please do referring into us or things aren't clear. Please do let us know, and we'll try to either get things smoother for you or learn from the experience as we're setting up what's a new clinic. So the template should be there in regional EMIS. You should have an ICE bundle for your filter function tests. And if there's any problems with access to it, please do let us know, and the contact details later on, and we'll try and make the pathway smoother. We're learning. Excellent.
A couple of further questions. When you said within 4 weeks, the blood test, it said 10 days for people with diabetes. Is there a rationale or reason for that?
Which bit of that? Sorry.
So the investigations to be done within 4 weeks. On that slide, it says 4 weeks, but in brackets, I think it does say, or parentheses, within 10 days if you're a diabetic or have diabetes.
I suspect that's because of, that's in the national specification. I suspect it's because of concerns for variability in renal function, and it'll be looking at up-to-date HbA1c. We will be flexible about that.
Okay. And I think we'll just take one further question before we move on to Hannah. And that is to do with the CA125. Obviously, that's something on the presentation. We've just got a question saying that in NICE guidelines, it's perhaps not recommended for diagnostic purposes, only for treatment progress. So is there a rationale or thinking as to why CA125 is included in your form?
Once again, this is part of the national specification for this, and here it's being used as a filter function test. If you have, because of the vague presentations that are generally coming to this, if you have a lady with diffuse abdominal pain with a CA125 of 30,000, though it isn't recommended for diagnostics, it does rather focus an onward referral for abdominal distension and bloating. And I think that's really the reason it's here, is not to prevent you referring with a borderline CA125, but to catch people in whom it's very high, who this pathway will only delay. As I said, it won't diagnose, but it will stream.
That's fine, thank you. We've taken a few questions already. So if I can ask Hannah to please come and start her part of the presentation, and then we can wrap up at the end with any remaining questions. So hopefully we'll be able to do that. Can't actually see Hannah on there. Hannah come back again.
If she's having connection issues, I'll carry on through.
Continue then, yeah, that's great.
Yeah. So I'll just get back to the screen share again. Okay, so this is one of our patients. She was referred fairly early in the process once we've opened this up. So this was a 77-year-old lady. This is one of our gut feeling referrals, and I think we ended up with a process of conversation between us and the GP as we saw this patient through that was actually really useful. And this was a patient who presented with weight loss, loss of appetite, and dependent edema. They'd been through two-week weight pathways, one for anemia, and was seen on an iron deficiency anemia pathway where she shouldn't have been because she wasn't iron deficient. She had a microcytic hyperchromic anemia with a ferritin of several hundred, and this was sort of one of the guiding clues that we had as we were putting her through it. She'd actually had quite extensive preceding investigations. She'd had a CT thorax, abdomen and pelvis. She'd had a chest film. She had an ultrasound of the pelvis, ultrasound of her abdomen, and quite extensive blood testing in general practice. And this was a case where the GP knew there was something wrong. This was a lady who was really, really well, who was fading away. And when we listened to the story from the referral and listened to the patient's initial triage, we thought, this is a lady we need to see. We saw her in clinic, and when you listen to her, it really was something that had changed, rapid weight loss. And when we saw her in clinic, her temperature was 39 or 40 degrees. She had a couple of courses of antibiotics in general practice for respiratory symptoms. And we were able to put together the investigations she'd had, clinical investigations in this history of relapsing symptoms suggestive of chest infection, along with changes on her CT that weren't reported, and we could speak to a radiologist now with our MDT connections and get some advice on those. And we arranged discriminating investigations for this lady. We had a clinical diagnosis suggestive of pulmonary fibrosis. We CT'd her and we arranged an autoimmune screen. And this lady had an ANCA-positive pulmonary vasculitis with early renal involvement. and the connections that the pathway's got within the MDT, and not focusing on a single treatment group, allowed us to speak to our respiratory and renal teams, and we got this patient started on what's almost certainly lung and kidney saving chemotherapy within a week or so of referral, after this patient had bounced back and forth several times within general practice and twice into a secondary care arrangement. So these are the patients we hope to find answers for. We hope we've got this lady before there's been significant lung damage, because things look relatively early on the CT. And it's have a think about your patient group. Is there someone who we can see for you? Again, we think that actually this has been a huge unmet need within the current rapid referral pathways, and we really hope we can both find a place for your patients and also give them, provide them with answers. And I'd just like to thank you for inviting me for this and letting us speak about it. But also be very happy to open the floor to any further questions.
That's great. So just wanted to ask about how long did it take in that case study for the actual diagnosis? We've had a question about that.
I think the longest we've taken to put someone through this pathway and leave with a diagnosis is 14 days from referral. In that time, this patient had a CT, autoimmune screen, and a face-to-face clinic appointment. And this is one of the reasons we are specific about our filter function tests and referral. It means we can see that referral, generate a patient-specific pathway of investigation, and get it started as soon as a referral is received. This lady, she'd been through a couple, she had a lot of investigations already. We could sit down and look at them and decide actually we had to see this lady. And the clinical diagnosis backed up by the radiology findings was essentially made in clinic, I think 3 days after referral. And I think the CT was several days later. The discriminating investigation for this lady was a serum anchor.
Okay, that's great. We've got Hannah back. Hannah, do you want to say it's okay. Do you want to say some closing remarks or anything about the whole process?
Yeah, I think you've covered the case study. I think we're just that point of access for people who fall into that grey area, perhaps. And when I've done previous sessions with GPs and AMPs, immediately people think of a patient. So the patients are out there. I think it's just raising that awareness and finding an answer. Because like the lady Michael talked about, she's been so heavily investigated with no real answers. And, you know, we managed to get an answer for her. And more often than not, these people have come under 2-week rule pathways, and unfortunately there has been no answer. So I think it's really beneficial, and I think it's come at a good time, especially after the COVID pandemic. I know especially, I think cancer research found that there were fewer people going for screen. I think it was 300 million fewer actually. The effects are massive, so there's a need for the service.
Hannah, I was wondering, we've got a question in the chat about how the GPs access the referral form from their system. Now, it's been quite a long time since I've spoken to Alicia, and I don't know the answer to that question, but we might have to take this colleague's name or contact details and get back to them.
Yeah.
Because I don't know precisely because obviously I haven't worked in general practice, and my experience of it is not in this area. It's down in sort of North Manchester. I don't know the specifics, so we might have to come back to.
I can send some information forward, but generally it's done through e-referral.
But I'm afraid we're not au fait with systems, so we will have to find information and get back. If you want to take our email address that's on the live stream, if you want to email myself or Hannah, we will get you an answer for that as soon as we can.
That's great. Michael, another question. Obviously, part of the referral, it talks about gut instinct, and that's a very interesting tool. I want to spend just a few minutes with both of you discussing this. What do you understand by gut instinct for someone who might be that, and what kind of things, apart from perhaps weight loss or they look slightly a bit unwell, would you want us to write in that piece of paper?
So I think that's completing the bit of the puzzle that we don't see in secondary care. General practice is generally the only part of the NHS that's allowed to use time and history as a diagnostic tool. And that's, I think, one of the big strengths of general practice in the UK, is that you watch pathology evolving over time. And generally the things that we're keen to know about is people who've become ill. And generally they haven't been. So people who are frequently attending, who are losing weight, who are acquiring pathology for no good reason. They're the kind of people that we think this pathway is for. People who've been through other 2-week weight pathways and where there's a strong suspicion of physical illness. We have had some patients with severe psychological illness through the pathway, or with significant problems out in life outside their physical health that has actually caused the physical symptoms that we've got. We are still going to see those people. We can't really fix them. We have to refer them on. But really, the things we're looking for in that gut feeling are the bits that we can't see in general practice, and that's that long-term relationship and watching pathology evolve over time.
That's great. Hannah, do you want to add anything to that?
I think that covers it really. I think what I quite like to have on that additional comment section is a good chunk of the GP clinical summary and history sheets, as Michael said, because we don't know these patients. So if we can get as much information as possible on the referral form, we provide a box for that to go in. It really does help us.
I think Jen's made a really good comment in the chat, is that actually I think that acknowledgement of the general practitioner as clinician is the left hand to the right hand of this process. As I said, we're fairly tight on resource, but that's really what we're here for, is those patients who are ill but don't know why yet. And that's really what we see as our core referral criteria.
That's excellent. Just a question for either of you, really. I know today's aimed at general practitioners by and large, but can the actual team who also perhaps work with general practitioners like ANPs or other specialist nurses who actually see patients, could they access the same referral form or not? Or do they need a signature from a GP? Could you just explain, just because obviously we've got mixed modalities of working in big multidisciplinary teams with a huge amount of experience in different realms. Just thought I'd ask that question.
As far as I know, the referrals aren't locked to doctors.
Yeah,
I think we acknowledge.
I've done some training with some practice nurses and ANPs, and I believe some practice nurses run their own clinics. So yeah, no, absolutely. I mean, even if a patient presents to the practice nurse and they think is suspicious of cancer, if everyone knows about it, raise it with the GP and refer. More than happy.
Great. Any final comments from Michael or Hannah before I close the evening?
Once again, thank you very much for inviting us.
Just one quick question while I've got everyone. We are hoping to develop the service to run alongside A&E. Now, the way we wanted to work it is on a discharge summary for GPs to be aware that A&E has recommended a referral to the RDC. We just wanted people's thoughts and opinions on that, really, and if they could see that working in general practice.
Mm-hmm. Great. Well, I'll put the feedback form both in the chat function here and also on the YouTube description. So people who are watching this back can perhaps get back to you, Hannah, with an answer to that. And also the person who's asking a specific question regarding System 1 can also contact you either via that email address that's provided or via the feedback form. Great, and hopefully you'll get some responses with that. I want to thank you all for your time, attention tonight. Tonight it's been live at Monday, 23rd of August. It's just coming up to 8:20. And for those of you reviewing and watching this at a later time, I hope you found it useful and enjoyable. And feel free to just look down and fill out any of the comments or reply back to us. Check out our further videos on Med Talks. We hope to entertain, educate, and inspire. Thank you so much. And